Welcome everybody to our November edition of the Cafe University webinar series. I am Rachel Nethery. I'm a faculty member in the Department of Biostatistics at the Harvard School of Public Health, and I'm also an internal Cafe team member. And I help with coordinating these webinars. So ideally, these webinars are meant to be educational and to cover various climate and health topics, occasionally presented by folks internal to CAFE, or like today, by visiting experts from around the world. Content can vary widely from data science related tutorials, grant writing tools and tips, lectures on advanced topics in climate and health, and then all the webinars are made freely available on the Cafe University YouTube website afterwards. So today we are extremely fortunate to be joined by Dr. Saria Hassan from the Emory University School of Medicine. And Dr. Hassan is an assistant professor in general medicine there. And she's an implementation scientist whose work focuses on addressing the needs of people living with non-communicable diseases following climate-induced disasters. And so today she's going to be teaching us about implementation science for climate and health. We are delighted to have her. Thank you so much, Dr. Hassan, for joining us. I am going to let you share your screen and take it away. For all attendees, we will hold a more lively question and answer session until the end, but feel free to put any questions or comments that you have in the chat as we go along, and Saria can address them at the end of the presentation. Thank you, Saria. Take it away.
Thank you so much, Rachel. And can I just confirm you're seeing everything okay?
Looks great to me.
Great. Well, thank you so much to the Cafe for this invitation. Always wonderful to be able to speak about two subjects I'm very passionate about, both implementation science and climate change and health. So I have no disclosures. And so our outline is pretty straightforward. We're going to start talking about climate change and global health equity. And I will say the majority of our talk today and the time today will really be focused on how all of this is absolutely critical when we think about health equity, both locally here in the US and globally. We'll then talk about how these challenges in terms of climate change and global health equity really means that we need to do more around adaptation and climate change and health adaptation. But recognizing that this comes with many challenges. And there's been a lot of literature out there really talking to us and discussing the challenges of adaptation. And this is where implementation science comes in. And hopefully I'll make a strong case for why implementation science is very well suited to address some of these challenges that we see in climate change and health adaptation. And then hopefully I'll have time to give you a few examples of how I've applied implementation science and system science tools to address these elements of climate change, health adaptation. So with that, let's get started. So you are all here today because this is not any news to you that unfortunately, as we see with this warming stripe graphic, this visual representation of the change in temperature over the past 100+ year, each stripe representing the average temperature for a single year relative to the average temperature over the entire period. So the shades of blue mean cooler than average years, and the red unfortunately shows years that were hotter than average. And as you can see, over the last several decades, we have been becoming more and more red. With this, unfortunately, have been a myriad of climate change effects that have had a lot of science and literature out there, and the IPCC reports are a great resource to understand everything from the physical science to the impacts, adaptation, and vulnerability that this global warming is inducing. And there are a myriad of these effects. And so while today I focus mainly on climate-related extreme weather events in my examples to you, keeping in mind that this is relevant to many of the other climate change effects that we see. But this audience is probably well aware that this is all a result of greenhouse gas emissions that are really leading to this these climate change phenomena. And unfortunately, there is a significant global mismatch between greenhouse gas emissions and the burden of climate change. In this graphic, those countries in red are free riders, those countries that contribute the most in greenhouse gas emissions, but suffer relatively the least in the impacts of climate change. And then there are the forest riders, those the exact opposite, contributing the least in greenhouse gas emissions, but unfortunately will suffer the most from the impacts of climate change. And when I say impacts of climate change, today will be really focused on the impacts of climate change on human health. In this beautiful wheel from the CDC, you can see those climate change effects in the middle. Anything from air pollution changes to extreme heat to sea level rise. And then you can see the multitude of ways in which these climate change effects impact health. And so I know, regardless of what your area of specialty is, your area of health that you are interested in is somewhere on this graphic. And so really a reminder that regardless of where in public health spectrum or health that you work in, climate change is impacting it in some way. But my personal interest has always been in non-communicable diseases. And you see these really spread throughout this graphic, a reminder of the ways in which climate change impacts NCDs. And why do I focus on non-communicable diseases, which I will refer to as NCDs? I focus on it because it is another striking example of global health disparities. You'll see the 5 NCDs shown here. And we know that 41 million people a year, 74% of all global deaths are due to NCDs. And unfortunately, when we look at premature deaths, deaths before the age of 70 due to NCDs, 86% of those occur in low and middle income countries. 77% of all NCD-related deaths occur in low and middle income countries. So clearly a realization that when we're thinking about global health disparities, we have a very unfortunate, striking one when it comes to NCDs. How does it relate to climate change? I showed you on the wheel where there are many areas in which NCDs are impacted. And this impact is both direct and it is indirect. And we are starting to build more and more of this evidence around the pathways through which climate change impacts non-communicable diseases. And so I'll show you the graphic in a different way of global health inequity due to climate change. I showed you that climate change impacts NCDs, that NCD disparities exist, and this will lead to changes in mortality. And so when we now look at this cartogram that shows you the carbon footprint, so again, the more swollen the country, that means that there is more of it. So in the top graphic, more of a carbon footprint. The lower graphic now showing mortality, showing us that those countries that are the smallest or skinniest within the top graphic are going to be suffering the highest mortality due to climate change, of which that impact on NCDs is one of the contributing factors. And so I term this the new double burden for low and middle income countries. We have NCDs, we have inequitable effects of those NCDs, and I've shown you the inequitable effects of climate change. And so unless we act at a global level, this new double burden will continue to worsen global health disparities. And it is really in this context that a lot of my work has been born. But this is not only a global health disparity. For those in the United States, this is a local problem. Those climate change inequities that we see in a global scale, in a global level, we similarly see here very locally. And this EPA report from 2021 outlines the myriad of different ways in which climate change will contribute to health inequities in the United States for multiple different demographics, for multiple different socioeconomic statuses. The data I'm showing here is just for Black and African American individuals, but just as striking for Native Americans, just as striking for the Latinx community as well. The highest increases in childhood asthma from climate-driven changes in PM 2.5 will be seen among the Black and African American population. The highest increases of mortality and the highest rates of labor hour loss will be seen in this population. So those health disparities that I showed you at a global level are also striking locally. And as Ban Ki-moon put it, climate change affects us all, but it does not affect us all equally. Those who are the least able to cope are being hit the hardest. We spend a lot of time in the adaptation space thinking about how to operationalize this idea of vulnerability, the vulnerability of human health to climate change. Understanding that in many ways it is a function of your exposure, the degree to which you as a person where you live are exposed to these climate stressors, sensitivity, your underlying chronic illnesses, your underlying age, or other disabilities that might make you more sensitive to climate change stressors. And then ultimately that ability to adapt, right? This notion of adaptive capacity, your ability to change yourself, their health system, the community that you're in, so that you can better overcome the stressors of climate change. That ability to adapt is what relates to adaptation, which we'll spend a lot of time focusing on today. Right? So adaptive capacity is the property of a system to adjust its characteristics in order to expand its coping range under existing climate variability or future climate conditions. You're designing and implementing effective adaptation strategies to react to those evolving stressors. And so adaptive capacity is related to adaptation. We need adaptive capacity, and we need to overcome barriers and leverage facilitators to be able to conduct actual adaptation. And it's that adaptation, right? It's that adaptation that's going to help us get over this double burden. It's going to help us adapt. Those strategies are what we are looking for so that we can adapt and overcome the inequitable effects of climate change on chronic diseases and other health effects of climate change. And through adaptation, we hope that we can reduce the global health disparities that are a result of climate change. And so where are we with adaptation, and in particular, climate change and health adaptation? And so this is just to emphasize that today I'm focused on adaptation because it is one of the spaces in which implementation science, I believe, and with some others as well, that implementation science really has a big role to play. So adaptation is really that process of adjustment to the actual or expected climate and its effects in order to moderate the harm or exploit the beneficial components. So not today really focusing on mitigation, but recognizing that there is an overlap, that there are some adaptation strategies that will also lead us to reduce our greenhouse gas emissions, as you see here. But furthermore, I'm focused on a specific aspect of adaptation because we are talking about climate change and health. And in particular, we're thinking about an adaptation that addresses the impacts of climate change on health, those policies, programs, and interventions that are aimed at reducing the health risks that are associated with climate change. And so these adaptations will build on essential public health services and will serve to strengthen the core health system functions to potentially offset these risks. And so in the paper I cite here, they give you some examples that allow us to understand what some examples of these essential public health services are and what they might look like if we were to translate them for the purpose of climate change health adaptation. And these are wonderful examples that will kind of probably and hopefully ring a bell to some of this work that many of you might be in the space that you might be in. So surveillance, public health communication, preparedness planning, early warning systems, training of health professionals about climate change and its health, and of course, the data that we need to support public health action. So a few examples of how, again, these public health services that many of you are engaged with and involved with can be translated into climate change adaptation work. And this wonderful paper by Hassan et al. Really helps us understand what it means to have evidence-based public health approaches to climate change adaptation. And there really has been in the last decade a movement of global efforts around climate change adaptation. These include here in the US, the Centers for Disease Control and Prevention, the BRACE initiative, Building Resilience Against Climate Effects. This really provides a framework for adaptation, a 5-step process that allows health officials to develop strategies and programs to help communities prepare for the health effects of climate change. And of course, you're all extremely familiar with the Lancet Countdown, which has really helped us raise awareness around the importance of adaptation and really understanding what the climate change impacts on health are. There also has been the United Nations Framework Convention on Climate Change that has moved us to think more concretely about what the adaptation process looks like, from assessing the impacts, from doing vulnerability assessments, planning for adaptation, implementing, and importantly, monitoring and evaluating. And I commend the UNFCCC to really have this project that's really bringing together a knowledge hub of what adaptation strategies are being implemented, what's already being done, and what do we know about the effectiveness of those adaptation strategies. And so I would look forward to seeing, as this adaptation knowledge portal is built and populated, that we can all continue to share in knowledge. And what I hope I'll also impart to you is the real role that implementation science can play in making sure that information that's put into portals such as this can really be informative in our ability to understand how to adapt things that are being implemented in one context to another context, but also understanding their implementation that might help us understand why or why not those strategies are successful or not successful. But really, this framework convention on climate change has also really pushed this idea of national vulnerability and adaptation assessments. And the steps of that vulnerability and adaptation assessment you see here. So now we're looking at really the steps towards national level adaptation. And as we understand these various steps, we understand that this really comes with several reasons for the WHO and others pushing for these national vulnerability and adaptation assessments, that they help us in understanding health risk, identifying those vulnerable populations, guiding policy and planning, helping with resource allocation, monitoring and evaluation, multi-sector collaboration, enhancing our public awareness, and preparing for emergencies, all aspects that are also can be translated into those adaptation strategies that, again, will help us reduce our vulnerability to the impacts of climate change on health. And as we think about how countries are doing, I use this mainly as an example to show some of the challenges that we are facing, in this case, at a national level with adaptation. And so this WHO report that said, okay, how are we doing within these nations in terms of moving the needle forward around climate change and health adaptation assessments and plans? And so you can see here that there has been a shift in terms of the number of countries, including low and middle income countries, that are doing more around health vulnerability and adaptation assessments, which is terrific. But what the report also highlighted are some of the continued challenges, which is why only 54% of countries still have had this vulnerability and adaptation assessment done. So the fact that there's a need to strengthen the comprehensiveness of strategies and plans, and as you will see, a lot of this means that we need to understand what works and what doesn't work and why, and that's a big part of where implementation science will come in. That implementing action on key health and climate change priorities continues to be challenging. Again, if we are to understand those barriers and the whys, implementation science can give us those tools. And of course, the financial aspect of things, which implementation science in and of itself, as you will see, we cannot address, but in providing the evidence and a stronger rationale for some of these adaptation strategies, hopefully will bring with it some of that financial support. So one example, those national adaptation plans, of some of the challenges that are facing different levels in terms of doing adaptation to really address the impacts of climate change on health. And it's being termed the adaptation gap, right? These challenges that are related to climate change adaptation. And the efforts to adapt the impacts of climate change really face a number of significant challenges. And yes, part of it is financial, but part of it is the evidence. What evidence do we have that one adaptation strategy can really impact a certain health outcome? But in addition to that, how do we know where context fits in? An adaptation strategy that works in one part of the world may need to be adapted in some way for it to work in a different part of the world. Context matters, as we keep saying in implementation science. The recognition that this work, by its nature, is multidisciplinary and interdisciplinary. And as you will see, that really means that we need to know how to form these teams and work collaboratively in these interdisciplinary nature teams in order to be successful. And that has contributed to the persistent adaptation gap. And of course, this idea of adaptive capacity, the ever elusive idea of adaptive capacity, is how can we really understand the adaptive capacity of a health system, or of a nation, or of a government, or of an individual? How do we operationalize this idea of adaptive capacity? And as that science, I think, grows, it will really help us address this adaptation gap. And ultimately, but perhaps most importantly, the recognition that adaptation strategies must address and reduce health disparities. And as we think about that, how can adaptation for sure be done with health equity in mind? And so as I look at these challenges, and you see them in the wheel here from the scoping review by Ansa et al., I think of implementation science, and I recognize that implementation science can help us address many of these challenges. And fortunately, I am not alone in these thoughts. Some of the big players in this field, from Jeremy Hess, Christy Ebbe, Gila Netta, all the wonderful papers out there that I urge you all to look at that help us understand really the role of implementation science in addressing climate change health adaptation. Also, several websites that you can look at, and the NIH has really spearheaded some of this thinking around the role of implementation science. And even the NIH Climate Change and Health Initiative really have their core elements here that you see in the wheel, the core elements supporting the areas of science around climate change and health. And you can see that dissemination and implementation science are highlighted. And so hopefully I will continue to explain to you and hopefully make the case that it fits here. And if anything, it's a really critical part of this cogwheel in making sure we can advance the science and address climate change and global health inequities. So let me start making this case of why implementation science and what the role of implementation science is in helping us address some of these challenges in climate change health adaptation. So we'll start with some basic definitions. The latest research shows that we really should do something with all this research. It's the idea that in implementation science, we are not here to reinvent the wheel, but we are here to recognize that evidence needs to be translated into practice and policy. And in order to do that, we cannot wait the 17 years that it takes us to turn 14% of our regional research to the benefit of patient care. So this traditional pathway, unfortunately, has always been very demoralizing for those of us really trying to impart change, but especially in the era of climate change. We do not have 17 years to wait around for, again, original research to benefit patient care. And so implementation science as a definition is the study of methods to promote the adoption and integration of evidence-based practice into interventions and policies into routine healthcare and public health settings. Implementation science, as you will see, addresses a no-do gap. It identifies barriers and enablers of effective programming and policymaking. It engages the community and stakeholders throughout the process. And it uses that knowledge and engagement to develop effective delivery approaches to eliminate that no-do gap. So a few definitions. I will be referring to implementation science, but in some ways we'll be talking about implementation research in my use of terminology. The differentiation is seen here: implementation science, the study of methods to promote the integration of research findings and evidence into healthcare policy and practice, whereas implementation research refers to the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings to improve health outcomes. And dissemination research, of course, is the study of targeted distribution of evidence to a specific public health or clinical practice audience. So again, for the majority of this talk, I'll be using the term implementation science, and many times I'll be referring to implementation research. And implementation science, when we think about it on the continuum of science from T0 to T4 translation science, we are really in that T3, T4 category. And this beautiful graphic from Brown et al. Really helps us understand in the real world, we start with pre-intervention work. Could a program work? And we go to those efficacy studies. And then once we have efficacy studies, we say, does a program work? And that's where we get into the effectiveness studies. But then we have to take it into the real world. And in the real world, that's when we want really the range of implementation science studies that allow us to go from local knowledge to the generalizable knowledge that we're always seeking in D&I research. And implementation science, as I mentioned before, is truly multi and interdisciplinary. It really sits at the chiasm between all of these sciences, from the social, the clinical, the population, and the engineering sciences. And if you see any of the implementation science teams that are out there, especially in the realm of climate change and health, they really do need to rely on all of these disciplinary expertise in order to be successful. Implementation science also exists along a continuum from operational to health systems research. There are many other similar fields that have Venn diagrams that overlap to some degree with implementation science. That includes knowledge translation, quality improvement, M&E work, operations research, and impact evaluation. But really thinking of how implementation science sits along this continuum that goes from research utility being local to really much more broad. Again, that goal of generating generalizable knowledge. But also in implementation science, we're interested in behavior and mechanism. We are interested in the why and the how. And really, as we think about a health intervention and its impact on a health outcome, really understanding the contextual determinants, but also the personal determinants that might, again, decide whether or not and to what extent a health intervention impacts a health outcome. And ultimately, implementation science allows us to address a no-do gap. This idea that when we have a health problem, it's not necessarily because we don't know how to solve it. There is likely, and in many cases, knowledge out there that tells us how to address the specific health problem. But there is a performance gap. For some reason, it's not happening. And when there's a performance gap, that leads to worsened health outcomes. That is our outcome gap. And we really seek to understand the evidence that's available for us to address the performance gap. And then again, the behaviors, the policies, and the contextual factors that are leading to us having that gap, the why. Why is what we know works not working? Why is what we know should be implemented not being implemented? And when we do this in implementation science, we recognize that we as the researchers do not have the answers. And really making sure that we're engaging the key players, the interested parties from the very beginning to better understand the why and the how. And ultimately to understand the why and the how for a certain context, but creating that generalizable knowledge that allows us to see how it can be translated into other contexts. Implementation science is ultimately a science, and it has tools within it that help us bring rigor to the field and a myriad of other benefits. These include theories, frameworks, and models, which I'll talk a little bit more about. It includes a focus on implementation outcomes and not just effectiveness outcomes. It really necessitates that we consider non-traditional trial designs. And I won't be talking too much about this today, but as you read more in the implementation science literature, see that we're not relying on just randomized controlled trials in implementation science. And then evaluation includes process evaluation, formative evaluation, and summative evaluation. Really, these pillars kind of helping us bring rigor to the field of implementation science. Theories, models, and frameworks are perhaps the most confusing part of implementation science, and we're getting better and better at categorizing them and finding ways of identifying the best ones to use. They are differentiated here. For the most part, I'll be talking about frameworks today. And they're really strategic action planning models that provide a systematic way to develop, manage, and evaluate interventions. The differentiation between them is very nicely outlined in this kind of classic Nielsen et al. Paper. It's actually just a Nielsen paper from 2015 that we all continue to refer back to. And the role really of these theories, models, and frameworks is to allow us to have a systematic structure for developing, managing, and evaluating interventions. And you'll see how this can come into play and become very important when we're thinking about climate change adaptation strategies. It can inform the selection and development of those strategies. Again, we'll provide you an example of how they can be very helpful in climate change and health research. They enhance the interpretability of our study findings, provide guidance on what we should be measuring, and really give us an opportunity to advance our understanding and the field as a whole. There are many frameworks in implementation science. And then again, Nielsen's paper helps us categorize them and start to understand where they fit and why we might start to use one versus another, depending on what your question is, depending on what phase of implementation research you're in. Again, urging you to refer back to that paper for more guidance. As I mentioned, implementation science focuses on implementation outcomes. Right? And these are those from Enola Proctor's implementation outcome paper that are things that we continue to refer back to and make sure that we continue to address in implementation science. And why? We do that because implementation science is really the understanding the how, right? This idea that we have these evidence-based practices And we have those health outcomes. And in the traditional pathway of research, we look at the practice, and then we look at the health outcome, and we don't do anything with this big black box of unknown in the middle. What implementation science does is it takes away that big black box and allows us to understand the how. How are certain intervention strategies reaching and resulting in these health outcomes? In order to do that, we need to understand what implementation strategies are being employed. We also need to understand these implementation outcomes that in many ways help us understand why or why not an intervention is successful. This is truly the implementation pathway. So in the focus of much of the implementation science world is really in better understanding this implementation pathway. I would not be doing justice if I was not to mention probably the best way of explaining implementation science, which Dr. Curran had very nicely outlined for us. The intervention is the thing. Effectiveness research is, does that thing work? But implementation research is how. How can we help people and places do the thing? And the strategies, that's the stuff that we do to help people do the thing. And those implementation outcomes are how much and how well are people and places doing the thing. So urging you again to go to Curran's paper that simplifies really our way of approaching implementation research, where implementation strategies fit in, and then implementation outcomes. So hopefully I've laid out some of the key elements of implementation science. Systematically tackling knowledge practice gaps, requiring interdisciplinary collaboration, engaging stakeholders, using theory to explore the mechanism, the how, including rigorous multi-level evaluation, and seeking really to create that generalizable knowledge. And if you start to look at that and look at the list of challenges that I gave you before around that adaptation gap, we start to see how these key elements in many ways can very directly address these challenges to adaptation. You will see that I grayed out the financial support, but again, making the case that if we can build the evidence, the financial support will be easier to obtain. One thing I've left out here that I want to just pause and give you more information about is the role of health equity and the role of implementation science in helping us better address health disparities. And this has really been a field of implementation science that I have been privileged to see grow over the last several years. And for those of us in the health disparities world and really work and research trying to target health disparities, implementation science has become more and more helpful for us. And I make the case in the same way that adaptation strategies really need to address and reduce health disparities, implementation science can help us get there. First, just to make sure everybody's on the same page, equity is the absence of avoidable, unfair, or remediable differences. Health equity is the fact that everyone should have a fair opportunity to attain their full health potential, and no one should be disadvantaged from achieving this potential. And I like to make the distinction that we are talking about equity. We are not talking about equality. And there is a striking difference, right? So if you see in this clear graphic, equality, I give everybody the same bicycle, they're not going to all get from point A to point B. But if I really adapt that bicycle, tailor it to the needs of the person, then I can make sure I achieve equity and everyone can reach from point A to point B. And so in implementation science, we have a unique ability that working with stakeholders in the community, we can better understand that how and that why. So we can better tailor that bicycle. We can better tailor that intervention so that we make sure that those interventions are not going to worsen health disparities. And so as Bowman and Kabasa put it very nicely in their paper, there are really multiple ways in which we can think about how implementation science can help us address health equity. Implementing what works, designing and selecting interventions with implementation in mind, focusing on reach from the very beginning, developing the science of adaptation, and using an equity lens when we think about implementation outcomes. So this idea of reach, this idea that when you put an intervention or roll out an intervention, what proportion of your population actually receives that intervention, right? So if you don't think about that from the beginning, you are not going to be thinking about the ways in which you can make sure the intervention is equitably reaching everyone. Similarly, when we design and select intervention, we need to be engaging people on the ground so that we make sure that those selected interventions are really appropriate, they're acceptable, they're feasible, and they're cost effective for the populations, and especially those health disparity populations. Of course, implementing what works and developing those implementation strategies, if we have put all of this in place and keep all of this in mind, will help us reduce those inequities. And then adaptation. So here, not thinking about climate change adaptation, this is adaptation in the realm of implementation science. Recognizing that if we better understand how we can tailor, how we can adapt an intervention so that it's better suited to a population, we're much more likely to make sure that that intervention reduces health inequities. And thankfully, the literature has now really blossomed in helping us think mechanistically, systematically about how to incorporate health equity into the science of implementation science. This is one example of how implementation outcomes can be framed with a health equity lens. But there are many more examples out there that I don't necessarily have the time to go in, but urge you again to read about how people are really starting to kind of advance the science of implementation science so that we have health equity in mind. This paper here gives us a very directive tree to give us the disparity research phases and how they relate to implementation research phases. Again, if we go to this, we can still remind ourselves as we're doing implementation research of the different phases that we can integrate health equity, integrate that health equity lens. Thinking now about frameworks and adapting existing frameworks in implementation science, such as the Paris framework, so that again, it has a health equity lens. EQUIR, the equity-focused implementation research for health programs, is yet another example of these implementation scientists now saying we need to make sure that our work from the very beginning and our frameworks are keeping health equity in mind. And so as we think about reframing implementation science to address inequities in healthcare, these are the elements that I referred to below, but hopefully making the case that implementation science is truly very well suited to help us understand those challenges around adaptation strategies that we need to make sure are reducing health equity. And this paper from Netta and al. Really kind of framed it nicely. All of that, what I told you around where implementation science fits in the space of climate change health adaptation, and really thinking about the different recommendations for those approaches in climate change health adaptation work. Applying your implementation science frameworks, co-creating, analyzing the how and the why, and then of course measuring those implementation outcomes. And so with that, let's see how we can actually apply it. How can we actually go to some case studies and see how some of these implementation science tools have been used to really think about adaptation, climate change health adaptation, and more specifically, because of the cases I'm going to be giving to you around climate change related extreme weather events and chronic diseases. So the case studies that I'm going to provide for you will really address how we can adapt evidence-based interventions to a climate change and health context, how we can use implementation science tools, specifically those frameworks, to help us systematically understand barriers and facilitators to adaptation, and then how we can use participatory system science, this burgeoning area of implementation science, how we can use those approaches to select and tailor strategies to reduce the impact of climate change on health disparities. Now, I will say those examples that I'm presenting today are really focused on the top part of this wheel, the applying the frameworks, the co-creation, and with the hope of funding in the future, hopefully future projects will be analyzing the how, the why, and measuring those implementation outcomes. So as we move forward, we are going to turn our attention to the beautiful Caribbean. And as we move and start focusing on the Caribbean, we'll start to really focus on climate-related extreme weather events, which, as you all know from the IPCC report, have shown us that due to the changing climate, extreme weather events will be unprecedented. They will occur in larger magnitude, with increased frequency, in new locations, in different timing, and unfortunately, a compound of all of those things with new combinations of those extremities. And now, why do I focus on the Caribbean? Remember that framework of exposure, sensitivity, ability to adapt as the components that define vulnerability? Well, the Caribbean is highly vulnerable. Partly highly vulnerable because it has the highest storms per million per year. So very high levels of exposure. But I also argue that the Caribbean is highly sensitive in terms of thinking about non-communicable diseases and mortality due to non-communicable diseases. The Caribbean having some of the highest premature mortality due to NCDs in Latin America and the Caribbean. And this graphic looking at daily adjusted life years by type of NCD in 2019, you can clearly see the Caribbean islands in orange compared to the global world, that unfortunately the Caribbean surpasses the global data for all forms of chronic disease. And the reality for those of you in the Caribbean, and I see some names here I do recognize, goes back to 2017, but as recent as last year. This is a recurring problem that is now facing the entire world and repeatedly the Caribbean. And for those of us really interested in chronic disease, the striking reality is that the impact of these climate-related extreme weather events on chronic disease is dire. A paper looking at Hurricane Maria showed that at least 30% of the mortality after Hurricane Maria was due to uncontrolled chronic disease. These include myocardial infarction. They include the cardiovascular diseases, the renal diseases and dialysis patients. They can include diabetes and our neurologic problems. And they include mental health. They include mental health both directly as a cause of mortality, but also indirectly in the ways in which mental health disorders impact other chronic diseases. The reality of how chronic disease and disasters interact is real. And what is ultimately also a really striking recognition is that it drives disparities. So in this chapter that we wrote I think a couple of years ago now with Dr. Dabney Evans, in the book Health Disparities, Disasters, and Crises, we provide a framework that builds on the socio-ecological model to allow us to better understand NCDs in disasters and recognizing the multiple factors that contribute to understanding why disasters worsen chronic disease here in the US and globally. In a recent, in a health affairs paper that we wrote around understanding why, right? Understand what do we know about why chronic diseases does so badly in the setting of disasters? And some of the reasons that came out of the scoping review is probably no surprise to you. Disrupted healthcare systems, communication challenges, mental health challenges, the reliance on ad hoc volunteers, the access to clean water and access to healthy food, right? But ultimately, we realized that we really needed more evidence around how to integrate NCD management into individual level, community level, institutional level, and regional disaster preparedness and response plans. And that's really been the focus of our team, is really understanding how we can better address the challenges in managing chronic disease and disasters, right? Recognizing that adaptation can occur at multiple levels. So let me start by giving you an example at a regional level. Many of you might be familiar with the World Health Organization non-communicable disease kits that have been used for many years now in the Middle East, specifically around the Syrian refugee crisis and providing comprehensive NCD care to thousands and thousands of people. But the NCD kits are a contained box, a set of boxes that have within them everything you need to diagnose and to manage the main chronic diseases. And so the idea was, why can't these kits be used then to address some of those challenges I outlined in the scoping review, some of those challenges around access that really lead to poor NCD outcomes in the setting of a disaster? And so, of course, we bring on our implementation science hats and really thinking we have an evidence-based intervention that works in another context. Can we bring it to the context of the Caribbean and Caribbean disasters? And in order to do that, we need to make sure we have the right people in the room. Again, that element of implementation science that builds on the interested parties and the knowledge of interested parties, to first ask them, is this even relevant? Is this a possibility? Is this, in your context, something you think we should explore? And if that is a yes, then how do we do that? How do we better understand the feasibility and acceptability of using these NCD kits in disasters in the Caribbean? And so as we came together in January 2020, right before the pandemic, we created a research approach and a research plan that would allow us to better understand feasibility and acceptability. And really, to cut down to the chase, recognize that there were a lot of challenges with disaster preparedness and chronic disease, really that lack of integration that we saw from our scoping review. But recognizing that COVID-19 did provide us with very unique opportunities. That as a result of COVID-19, many people who in the beginning said they would have been skeptical. They would have been skeptical that the region of the Caribbean can come together and purchase items in bulk and then distribute them equitably among island nations. But of course, COVID-19 hit, and what did they do? They bulk purchased testing kits, they bulk purchased vaccines, and they distributed them. So COVID-19 showed us that it can be done. COVID-19 also provided us an opportunity to think about the focus on NCDs and disasters because of how we saw that NCDs were disproportionately affected by chronic disease. We put together a stakeholder report to report back to PAHO, which was one of our funders and collaborators. And as that report was being distributed, this happened. Not a climate-related disaster, but a huge disaster for St. Vincent and the Grenadines, nevertheless, impacting a significant proportion of the northern part of the island, causing a tremendous displacement and a complete halting of health service delivery in that part of the island. St. Vincent and the Grenadines were part of our stakeholder groups that were initially involved in our assessments around the NCD kits. And they immediately called because they saw the information and the data around feasibility and acceptability asking for those kits. We were fortunate to be able to deploy them and made sure that we took note of the lessons. That gets us to that importance of the monitoring and evaluation when you roll out an implementation strategy, in this case, the NCD kits. Recognizing that we need to understand the challenges of this, despite it having been thought to be feasible and acceptable. What are the challenges that are faced when we try to roll this out in real world? And so these are some of the lessons learned that you see here. Clearly a lot that we learned from this process, but still a very positive in terms of the feedback that we obtained around the utility of those NCD kits. And now PAHO is still continuing to evaluate the role of these NCD kits for disasters in the Caribbean. So an example there of adaptation, of using our implementation science outcomes of feasibility and acceptability to understand whether an evidence-based intervention can be adapted to the context of the Caribbean, and then ultimately rolling it out and studying its implementation outcomes. But as I said, adaptation can occur at multiple levels. So let's now shift to thinking about institutional level or healthcare facility level and the individual level. And really the goal of one of the grants I have from NIH is to really think about strengthening the capacity at the individual and the institutional level to address the needs of people living with chronic disease in the setting of climate-related extreme weather events. This work takes us to the Virgin Islands and Puerto Rico. Made the case that Virgin Islands and Puerto Rico sitting in the Caribbean have high levels of exposure. The case here being that they also unfortunately have high levels of sensitivity. They have existing high levels of health disparity that will only be worsened by the impacts of climate change. Within the Puerto Rico and the Virgin Islands, we work specifically with federally qualified health centers. These are government-funded centers that serve the underserved, the uninsured and the underinsured, with large populations of refugee and immigrants and lower socioeconomic status. And these amazing teams have come together over the last 4 years to really help us understand the challenges that they faced with past disasters in addressing NCDs, but also how we can develop strategies to, again, lead to that adaptation, to strengthen that adaptive capacity of people living with chronic disease at the individual level and then at the health system level. And we turn to implementation science. We turn to implementation science. Why? Because it can give us a structure to think about this very complicated problem. This is one of the many frameworks in implementation science, but one that is extremely relevant to this type of work. We chose the EPIS framework because it's specifically developed to guide the implementation of evidence-based programs in publicly funded settings. It identifies what those key inner and outer setting contextual factors are that we have to make sure we're considering when we're really thinking about the implementation process as it relates to adaptation, here trying to address chronic disease and disasters. And these are the phases of EPIS: exploration, preparation, implementation, and sustainability. And for really the bulk of our time, we have been focusing on exploration, right? How do we identify those strategies, those adaptation strategies that are needed really to help people living with chronic disease when disasters hit? And we did a lot of formative work. Here's a paper from some of that formative work that allowed us to really understand some of those barriers and facilitators. Really kind of turning to our qualitative work, but our qualitative work really embedded within the context of implementation science and utilizing the EPIS framework. And so we took the data that came out of our interview processes and really organized the themes by the inner and outer context factors of EPIS. Why? Because again, it allows us to think more systematically about the complicated problem. It allows us to then, when we start to develop solutions, think about solutions at the different levels, because we're thinking about things at the individual level or the organization level. So I don't have time to go through all of these results. The goal here is to really just show you how an implementation science framework can really take your qualitative work a step further in helping you systematically organize your results. And so we have the inner context, themes within the outer context, themes within the bridging factors, and then we can start to group those themes, those factors that we can leverage, things that were working really well that we need to continue to do, and then those factors that were challenges that our future adaptation strategies need to make sure they address. And then furthermore, what are those factors, EPIS factors, that the FQHC in and of itself can implement? But then what are those factors that we might need to engage policymakers in order to impact change or impart change? So with all of this formative work, we get a really robust and structured understanding of the barriers and the facilities. But from there, we need solutions. We need to really engage those interested parties to understand what are the best strategies to help us overcome these challenges. And for that, we turn to participatory system science. This is a methodology. System science, or system thinking in and of itself, is a way to describe and understand the causality and interrelations between variables within a complex system. It really quantifies the impact of those interactions if you then take a model and then actually make it dynamic and quantify. Critical, absolutely critical to this approach, especially in implementation science, is that it is participatory, is that it really takes the individuals, the interested parties, and allows them to develop a mental model of a very complicated problem. Within system science, this set of steps is called group model building. This idea of developing that graphic depiction of all of the variables that contribute to a complicated problem, and all of the things that are resulting from the complicated problem, and then how everything is related. So we go through these series of steps with interested parties, with the goal really of ultimately having that graphical depiction of the complexity of the complex system. And so for our study, again, the problem we are dealing with is the rising number of people with uncontrolled chronic disease after a disaster hits. And then we engaged interested parties, and you see them listed here, in that process of group model building. It's a series of sessions, which, because of COVID, we had to do initially virtually, and then towards the end in person. Really first having them think about the causes and the consequences that stem a lot from that formative work that I had shown you previously. But then allowing them to think about how those things are interrelated. And a very basic example, the topic, the problem, persons with poorly controlled chronic disease after a disaster. Mental health problems, as you know, exacerbate chronic disease. Chronic disease leads to complications. Complications lead to decreased productivity, negative financial consequences, worse mental health. In a disaster, this loop right here will continue and get completely out of hand. So one really small example of how the complexity of the system comes into play. But as you can see us here virtually modeling and thinking about the complexity here, it's not as easy and it's kind of messy. But it is really a wonderful way in which these interested parties can see on the screen in front of them what they have experienced and understand the different levels at which those experiences are driven. And this is one of kind of a preliminary diagram from the results from all of that work. The goal here, not for you to see the details, but to see the beauty of the complexity and to understand that within this beauty are a series of stories that explain the different areas that are ripe for intervention, the different areas that are ripe for strategies, for adaptation strategies that will disrupt these reinforcing loops and help us reduce the problem. Mental health, food insecurity, housing insecurity, provider access, medications, social support, awareness. And then with that same group, then you can sit down and say, okay, how do we now start to think about solutions? How do we start to prioritize approaches to address these challenges? So in terms of talking with the community, they developed a series of strategies that they wanted to address. Clearly, at the individual level around awareness, recognizing that awareness around the role of chronic disease when a disaster hits is critical. The focus is always on water, food, and shelter. But a week without your insulin is a death sentence. And so people recognizing the importance, being aware of why it is still important for your chronic disease management to be at the forefront of your mind. And so there's a lot of literature around climate and health awareness and the importance it plays there. There's a lot of literature around preparedness and the role it plays in reducing outcomes. So this was one of the strategies we did, was empowering our providers and helping them to better communicate chronic disease impacts in the setting of a disaster. Other things that are more at the system level that we are writing policy reports on because it may not be directly in the control, like we saw in the EPIS framework, in the control of the health center or the individual. The biggest one being food, something that people repeatedly complained about was access to healthy food, which only exacerbated their chronic disease. These were the packages that were sent to the Virgin Islands and Puerto Rico in the aftermath of Hurricane Maria. And as you see, and as someone says, you either get diabetes or hypertension in a box. And so as we think about the fact that we talked about exploration and really understanding what the best strategies are that the community thinks are the best strategies, let's now find those evidence-based things, those evidence-based strategies that we can adapt and bring in and now test. And that's the stage that we're in now. Is really identifying those strategies that we know are evidence-based that can improve ability to self-manage your chronic disease when you don't have access to a provider. Recognizing that we have a lot of evidence-based strategies out there that help us promote psychosocial support. And of course, the WHO has led much of that. And how do we now adapt that to the Caribbean? This is an example of us training some key partners, some community health workers, community outreach workers, healthcare workers, community-based organization leaders around just delivering psychological first aid and psychosocial support, right? Giving them some tools so that when a disaster hits, they're able to better manage those mental health conditions that we know are such an integral part of that complex diagram. And of course, it's always wonderful to be able to do that when you have a beautiful setting, which we only hope can be kept beautiful, but also the health of those living there can be kept as well. And the examples of what we can do, what evidence-based interventions are out there that we can start to think about now really implementing and moving forward is huge. And I think this is a space we're now in, now that we've identified the strategies that the community feels are important for us to move forward, how do we take now those evidence-based interventions and really bring them to the Caribbean context? And again, we don't want to reinvent the wheel. So when electricity and energy independence is a priority strategy for our community members from the work that we've done, we turn to people within Puerto Rico, such as at Juntas, who have figured out energy independence way before Maria, one of the few places that had light on after Hurricane Maria. And how do we partner with people like that to take a strategy that they've successfully implemented in one part of the island to now scale it up? So hopefully showing you the power of frameworks to help us very systematically think about complicated problems, develop strategies, and then eventually test those strategies so that we can then sustain them and hopefully scale. Before I turn away from the Caribbean and give you a couple of very quick other examples, I just want to make sure you're aware of this action-oriented research agenda for climate change and health in the Caribbean, that a group of key stakeholders in the region have really come together to put out there, and you can find this online. We presented this way back in COP26, but are really trying to push the realization that we have significant gaps in the Caribbean. So this is data that was released around articles and that by income group and region that are in the space of climate change and health. And you can see where the Central America and the Caribbean, we do dismally. And so really there needs to be more research, but specifically actionable research. Because again, this is where the role of implementation science comes in. So this kind of very comprehensive report, the website here, you can go, it's on the Earthmetic, Earth Nurse website, but also on the Yale website, gives us a framework to really understand where the gaps are for actionable research on climate change and health in the Caribbean. I know the WHO is moving to do this now for a larger region, to really give us a structure and a framework so that we can start to identify the gaps, many of which, of course, are adaptation gaps and implementation science gaps. So before I end, let me turn to another region of the world, because as you all know, these extreme weather events are not unique to the Caribbean or to North America. And one of the places, unfortunately, that has been hit repeatedly by these cyclones is Mozambique. And Mozambique, unfortunately, over the past 4 years, has been hit with at least one major cyclone per year. And Mozambique, like many other low and middle income countries, unfortunately, is suffering from that epidemiologic transition, where the second highest cause of death is cardiovascular disease. So again, repeated exposure to extreme weather events, high levels of chronic disease, that combination leading to worsened health disparities. So what can we learn from what we have in the Caribbean? What can we learn from that experience and bring it to Mozambique? And so we have partnered with the Instituto Nacional de Saúde. My Portuguese is getting a little bit better, funded by the Emory Global Health Institute, to think about really, again, developing those strategies to strengthen health system resilience or adaptation, really with a focus on chronic disease. And we found that there were very, very similar challenges in Mozambique around chronic disease and disasters, which I won't go through, but really to urge you to, if you're coming to the 17th Annual Conference on Science and Dissemination and Implementation, the D&I conference as we call it, we will have a poster really spearheaded by my former student, Erica Kanda, really showing how we've used another implementation science framework, the Consolidated Framework for Implementation Research, to really organize our thoughts around the challenges of chronic disease and disasters in Mozambique, and how we're now utilizing that to go into implementation strategies. So another example, another part of the world, just as relevant to understand what's working in one context, take it to another context, and really leveraging those implementation science frameworks. But this is not a global health problem. For those of you in the United States, this is a very relevant issue right here. Global health disparities as a result of climate change are also local health disparities that will worsen. So this is just to show you that all of that work that I showed you globally can be done right here and is needed right here in Atlanta, where I'm based. Why? Because there are certain populations within a city, certain areas within a city that unfortunately have much higher levels of exposure to the impacts of climate change. Historically, redline neighborhoods in Atlanta have more polluted air. They have more sewage overflowing during the times of flooding. They are more likely to be the same areas that have urban heat island effects. And this is no accident for those of you in the United States who are probably well aware of the racist policies of the 1930s that led to redlining, that changed really the investment and how investment was happening in certain neighborhoods, and those neighborhoods being those that were predominantly Black and brown. And so what this project really does is, again, think about those things of exposure, sensitivity, and adaptive capacity. And it then thinks about how we can look at that adaptive capacity, how we can develop those adaptation strategies to really strengthen the resilience of these communities to the impacts of climate change on health. And we turn again to implementation science and system science, right? The methodologies here can really be interrelatable to different contexts. And this is an example of how we've done exactly the same thing, just focused on climate change and some specific chronic diseases that were a priority for these populations. I'll give you the example of asthma. Similar diagram to what you saw before, right? Again, allowing those community members to see the complexity of their lived experience in a diagram. And then to take that to then develop strategies. And really thinking about what those strategies are and prioritizing those strategies, such as you see here, trash cleanup, raising awareness, community support groups, increasing tree canopy, things that we already know work in other contexts. How do we now start to implement them here in these communities? The first one being around raising awareness, which is what they wanted to do. So we created community climate champions, and now we're studying the impact of these community climate champions going out into their neighborhoods and really raising awareness around how climate change can impact their health. So in summary, climate change will worsen global NCD disparities unless urgent action is taken. Individuals with chronic disease are highly vulnerable to climate-related severe weather events. That vulnerability is a function of exposure, sensitivity, and adaptive capacity. That adaptive capacity is critical for adaptation, and adaptation is what is needed to overcome the impact of climate change on health. And adaptation, unfortunately, has been challenged. But implementation science provides us with a unique opportunity to inform adaptation and ensure that adaptation strengthens health equity. And hopefully shown you some examples of how those implementation science tools and participatory system science approaches can get us closer to moving the needle on adaptation. And so with that, I'll end. I know I've gone a little over my 1 hour, but hoping that we will have time for questions. So I'll stop there. Thank you so much.
Wow, what a fantastic and inspiring presentation, Saria. Just one of the best presentations I've seen in a while. I learned so much. So thank you so much for that. I see there's already a good amount of chatter in the chat, which we can address. And I really want other folks on the call to kind of lead the discussion here. So I do want to hand it over to them, but maybe as folks are just thinking about what questions they want to ask, I can ask one question. And then if you're thinking of, if you have your own questions, you can either put them in the chat or raise your hand and we can unmute you when we're ready. So just one question from me first, and then I'll hand it over to others. So when I was looking at your DAG type thing that you made as part of the participatory based system science project, I was amazed. First off, it's such a useful process. But I was also thinking how I would handle all the information that came from that DAG. The issues identified are so diverse, and I know that you worked with the team to sort of prioritize what issues you might be able to act on. But then even those issues that you kind of decide on as your targets for action can be so diverse. I'm just curious what your process is for going about sort of finding the evidence-based solutions in all of those spaces, because no matter what your particular area of expertise is, there's no way that you're going to have expertise in all of the areas identified in that DAG or by the group. And so I'm thinking I would be super overwhelmed, actually, like trying to then narrow down all the possible places that you could go to find evidence-based strategies, both in academic research and, as you said, in sort of like grassroots spaces. And so I'm just curious what the process looks like of going from that like great list of possible places to act to like identifying the most promising evidence-based solutions.
Yeah, thank you, Rachel. That's such a great question. And I think it really speaks to why you cannot do this as just a like health researcher, health disparities researcher. This is where the power of that multidisciplinary approach comes in. So that you have members in your team that do have that varied expertise that can look at a strategy that's coming out and say, oh yeah, we have evidence for something like that. Let me pull that paper and show you. So two things. So one, the complexity is overwhelming. I will not shy away from that reality. And as I've learned this process over the last 4 years, continue to be in awe of the complexity that comes out from this very community-driven, stakeholder-engaged approach. So it does really necessitate that you break it down. So even when we sit and engage community members to think about strategies, we have to just look at one little part of the diagram and these set of loops first. Let's really dive into what strategies can be used to address this before you move to another type of adaptation, because otherwise it's just way too overwhelming. Once you have a list of strategies, though, it is important for the community to prioritize. So what we've been trying to use, and we have a project now with King County in Washington State around extreme heat, with Jeremy Hess as part of that project, is trying to use the appease criteria. So the appease criteria have been classically used as part of the behavior change wheel to really prioritize strategies that are coming out of that whole process of the behavior change wheel that ends in those intervention functions, right? But can we use it the same kind of criteria of appease, applicability, practicability, I'm not going to remember all of them. Equity is one of them. Sustainability is one of them. Can we apply those to help stakeholders think more systematically about why they're choosing one versus another? Not that I just like this one better. So there really does need to bring again that implementation science to create some rigor and structure to that process of identifying which strategies are prioritized, but then really relying on the multidisciplinarity of the team to help us identify the evidence base. So, great question.
That makes perfect sense. Yeah, thank you so much. I will also, restate my call for folks to raise their electronic hands, and we can unmute you. If you have questions that you want to ask yourself, I can also read off some of the questions that came in the chat during the talk. So one from Nancy Andrade, who I think has logged off now, but she said, wondering if there are climate and health specific implementation science frameworks and models. If not, is there a need for them?
That's a great question. And I see Gila might still be on here, but there are definitely folks in the space of really thinking about this. I'm always a proponent of if we can take an existing model and add elements of it that can better address climate change and health. One aspect of this is adaptive capacity. This concept of adaptive capacity really isn't captured in our frameworks. So does it make sense for us to create a completely different framework or try to figure out how to integrate that into existing frameworks? So none that I know that exist completely independently. The papers that I've cited do offer adaptation frameworks, but not necessarily implementation science adaptation frameworks. And if anyone else on here knows of one, please do pop it in the chat, because again, I'm not the expert here.
Yeah, and a link. Oh, I see Gila just put one in the chat. Actually, I was going to suggest unmuting Gila in case she had anything to add on that as well. But it looks like she put some things in the chat. Gila, if you want to say anything, I think you're able to unmute yourself now. May not be working.
And in case she can't, I do think that, what she put in there are examples of frameworks that are being updated to include climate change and health. So not necessarily new frameworks, but those updates are so critical, and I hope they're engaging the climate change and health space in making those updates. But maybe if you can try to, there she is.
Oh yeah, I see you're unmuted now, Gila, if you want to say anything.
I think before, there's a lot of theory and rigor and testing that goes into developing a lot of these frameworks. And so where useful, but just need some adapting, I think maybe just a more efficient way to go than creating a whole new one from scratch out of thin air. So that's sort of my personal take on it. And in that paper that Saria referenced that John Belbis and early warning system developers worked on, they did apply CIFER and sort of saw the value in where it was useful, adapting some of the constructs. And actually, there's been a couple nice reviews of theories, models, and frameworks that have been used in the field, showing the degree to which the constructs are flexible. And so I think theories, frameworks, and models that are hopefully a helpful basis, but they're not, rigid things that need to be. So I think in and of themselves, these tools can be helpful. I'm not sure, like Saria said, it's a great example of where there are certain constructs that are important, not just for climate change, but I think in general, the idea of adaptive capacity, or maybe it's implementation readiness or other things. They're always concepts that can be added to these, but I do think they're a helpful basis.
Thanks, Gila. And thanks, Saria. That was a really insightful discussion, and thanks for putting some of the terminology in the chat too, so we can those of us who are not familiar with this field can go do some Googling. I also see there was a question in the chat from Amanda. Oh, thanks, Elaine. I see you're in the process of unmuting her now. Amanda, if you would like to actually ask your question, if you're able to talk, and you would like to actually ask your question directly, you're welcome to now.
Sure, Rachel. Thank you so much. And thank you so much for the wonderful presentation today. My question was related to whether or not there are particular dissemination and implementation and maybe even health communication strategies that are related to addressing issues related to climate and health that can be or should be compared through comparative effectiveness research to determine which is best for whom. And this is just, speaking from the perspective of I work for the Patient-Centered Outcomes Research Institute, PCORI, and we fund comparative effectiveness research. So it's definitely a question of interest for me with regard to this lens and focus in climate and health.
Yeah, thanks for your question, Amanda. And I think absolutely. I just don't know if we're there yet. I think part of the challenge we're having now is really having adaptation strategies that we test related to health outcomes, testing both their effectiveness and their implementation. So once we have that, then the comparative effectiveness is really where we need to go. And I think as much as we see with PCORI too, this movement to not only look at the comparative effectiveness, but making sure that we're also studying the implementation outcomes and the implementation processes, we're doing that so that then when we see results, we really understand the why and the how of the why one landed up more effective than the other. I don't know if that answers your question.
Right, it does certainly, and I appreciate your comment about how it just may not be ready. The readiness isn't, we're not quite there yet for CER. So that's something that I've somewhat observed in just my review of the literature and the readiness for this. So I appreciate your response. Thank you.
Thanks, Amanda. Elaine, I think Abigail is on the call, and she had a question in the chat if she's able to unmute herself and wants to ask it. You're more than welcome to go ahead, Abigail.
Yeah, thanks, Rachel. This is a bit of a long question here, but I'm really interested in connecting the kind of global work being done on climate and health and the domestic work here. And I think Dr. Hassan, you did a really good job at provided a really concrete example of how your work in the Caribbean and Mozambique has been used and translated into an Atlanta context. And was wondering if you could speak a little bit more about how implementation science and methodology can help bring learnings and kind of cross-pollinate between global health, climate and health interventions and local domestic US interventions here.
Yeah, no, I think it's a great question. I will say there's really a push to better understand this. I know NIH Fogarty was working on a case series around adaptation strategies, again, to help us understand what's being done globally and what's being done locally and some of the similarities. There was another group, I want to say it was PCORI funded, that was looking at community-based strategies globally and how they might inform US-based strategies as well. I think this is where the beauty of implementation science comes in, because the way we study adaptation, the way we study these strategies is really geared towards creating that generalizable knowledge. It allows us, gives us a unique opportunity to think about how that can be translated to a different context, right? So whether that context is going from US based to global, from global to US based. The field, I think the area of implementation science that we need to continue to grow is that adaptation space, right? So something that works in Mozambique or in Tanzania, and I want to bring it here, what do I need to adapt, right? What are those core elements? What are the adaptable elements as I bring them now into a different context? But implementation science truly is very well suited to allow us to understand when that can be done and how it can be done. So again, really, I think the power of implementation science in this field. I hope that answers your question.
Thanks, Abigail. Again, anybody else who has questions, we have a couple more minutes allotted for this in case you have questions, you're welcome to raise your hand or put them in the chat. I'm seeing a good bit of discussion in the chat about having this recording available. And so we always make these recordings available on the cafe website. And usually it takes us a few days to get it up there. But I think Elaine put the YouTube site, yes, in the chat as well. So you can keep an eye on that over the next week or so, and hopefully we'll be able to get this recording polished and uploaded there. Lots of excitement about this talk. Oh, it's a comment again from Abigail.
That's the one. Awesome. Yes. That's the project I was talking about, Abigail. It's a great one.
If no other questions, I think we can go ahead and wrap up. So huge thank you again, Saria, for this fantastic presentation. So informative and inspiring, which is a hard balance to strike. So this was definitely one of our best, largest audiences yet. So just goes to show how much interest there is in this topic and how important it is at this moment. So thank you so much for teaching us all about it. And we hope to have you back for future cafe events and hope to see you at our conference this year as well.
Thank you so much for the opportunity. Thank you.
Thank
Bye-bye.
you. Thanks. Bye, everybody.